whenever you're ready.
Now starting. All attendees are in listen-only mode.
Great. Hello, everyone. Thank you so much for joining today's webinar. My name is Kate Morales. I'm the Senior Program Director at the Hepatitis B Foundation and Director of Hep B United. Before we get started on today's exciting session on Hep B patient navigation programs, I'd like to quickly go over a few housekeeping items and let you know how you can participate in today's webinar. Please note that all attendees are in listen-only mode, so you will be muted during the presentations. You may submit questions in the question box, and any time during the presentations, we'll be reviewing them as they come in. And after the end of the presentations, we'll be holding a question and answer period. And this webinar is being recorded, so you'll receive an email with a link to view a recording of today's presentation after the webinar. So to share a quick note about Hep B United for those that are unfamiliar, we at the Hepatitis B Foundation are co-lead of the coalition with the Association of Asian Pacific Community Health Organizations, or APCHO. Hep United is a national coalition to address hepatitis B, which is the leading cause of liver cancer and a major health disparity among Asian Americans and Pacific Islanders. Our goals are to support and leverage the success of our local community-based coalitions across the United States to increase Hep B awareness, screening, vaccination, and linkage to care. And I'd like to go ahead and present or introduce our presenters for today. First, we will be joined by Dr. Karen Kim, who is the president of the Asian Health Coalition. And she's also a professor of medicine at the University of Chicago. Dr. Kim is also joined by her staff, Angela Forfia, who's the program director at the Asian Health Coalition. And our second presentation will be from Nira Johnson, who's the Director of Program Implementation and Capacity Building at the New York City Department of Health. All right, and I will go ahead and turn it over to Dr. Kim. Karen? Karen, can you hear me?
Hello. Sorry, I said that whole thing was being on mute. Can everyone hear me?
Yes, we can hear you now.
Okay. Sorry about that. First of all, again, I want to thank the organizers for inviting us to present and for the audience for dialing in for this webinar. We really wanted to share some information about our CDC-funded Project Phoenix, which is a program that addresses gaps in linkage to care for chronic hepatitis B patients. And we thought we could tell you a little bit about what we have been doing in Chicago. Next slide. So when you think about, next slide, please. So when you think about the Chicago metropolitan area, we are currently the 5th largest Asian American population in the United States. And you can see certainly in the Midwest, really we are the biggest Asian American population in the Midwest. I think one of the big problems, however, with our location is that despite being the 5th largest, we really lack resources and infrastructure for the delivery of Asian health. And so I think it's very, very important for us to create model programs to make sure that people, our Asian communities, have adequate access to care, which hopefully this program will show you we have been able to be very successful at. Next slide. I think it's also very important to know that we are not the only immigrant refugee population in Chicago. If you look at the African immigrant population, you can see in Chicago we have close to 47,000 African immigrant communities who are also highly at risk for chronic hepatitis B, and so a lot of our programming is to work both within the Asian American as well as the African immigrant populations. Next slide. And one of the ways that we have thought about addressing better or bigger capacity to address the needs of the Midwest Asian Americans is through a creation of an academic community partnership, which we have titled the University of Chicago Center for Asian Health Equity. And that is a partnership between the University of Chicago Medicine and the Asian Health Coalition to create the center. And really, we think of a four-part mission of this center, which includes to build capacity for Asian health research, to continue robust community engagement, for education and training for future pipeline programs and for other future leaders who would be interested in Asian health, and really to think about health policy and advocacy so we can have better dissemination of findings for Asian health. Next slide. So we were funded very generously by the Centers for Disease Control, the Center for Disease Control and Prevention from the CDC to develop a Linkage-to-Care model. And this is a program that is co-led both by Edwin Chandrasekhar, who is the Executive Director of the Asian Health Coalition, as well as the Deputy Director of the Center for Asian Health Equity on campus, and myself, and who you will be hearing from in a few minutes is Angela Forfia and other coalition staff members. We also, for this project, have four patient navigators representing several of our partner health systems, Heartland Health Center, as well as Sinai Health Systems. And we have a very active medical advisory board who has helped us oversee this project. And this medical advisory board is a multi-sector medical advisory board, which includes representations from our local health departments. Next slide. And we have previously described our program that was, again, funded by the CDC, called the Hepatitis Education and Prevention Program. And this program was really designed to increase awareness, knowledge, and screening around hepatitis B for Chicago's Asian immigrant populations. And this was really through the development of a community health worker model, which has been very successful in sort of reaching to marginalized communities. One of the things that we found, however, was that despite very active and robust screening and immunization, we still fell short of a robust linkage-to-care program. So despite being able to identify those who were at risk or who were infected with chronic hepatitis B, we really did not have a good model system for a linkage-to-care. And that's where this grant has come in to really help us. Next slide. And so if you think about gaps in continuum of care for hepatitis B, my guess is that this is pretty universal at many places, not just in the Midwest. But if you think about kind of patient processes, service roles, activities, and training, in terms of patient processes, we know that we are probably very good at education and counseling, and through the continuum all the way to being able to describe health screenings. We think about diagnostic processes all the way to maintenance of healthcare. But when we correlate that with service roles, particularly with the work through our community health workers, we find that our community health workers are outstanding working within the communities. But up to the point of access to care within healthcare systems, there was just a big missing piece. And this missing piece is what we are describing through our patient education program. Similarly, when you think about activities that we have done throughout the years to increase awareness for hepatitis B, this has taken many forms, both from provider education and community education. But where we really have fallen short, again, is thinking about taking our community health worker training model, which has been really robust and successful, but how do we get this model to work in terms of next steps for linkage to care for our chronic hepatitis B patients? Next slide. So our target population for this grant is really foreign-born individuals both from Asia and from Africa who are at high risk for suboptimal healthcare outcomes. And this particularly refers to those who are newly tested and diagnosed with chronic hepatitis B, as well as those who we have previously tested and diagnosed with chronic hepatitis B, who are lost to care or who are never in care. And what you can see at the bottom of this slide are two of our small media campaigns to try to target marginalized populations to come out and not only get screened and tested, but to make sure that they have adequate linkage to care. Next slide. So I'm actually going to turn the microphone over to Angela Forfia to complete the rest of the information about this program.
Great. Thank you so much, Dr. Kim. I'd like to start by giving you some background on our hepatitis linkage-to-care model, which includes patient navigation. And to put this work in context, I'll share how we developed and implemented this project across the Chicago metropolitan area. An underlying principle of our hepatitis B linkage-to-care model is that people who are diagnosed with chronic hepatitis B should be connected with a medical home. This ensures that there's a connection between the community health worker, the patient navigator within the clinical setting, and the primary care physician, as well as specialists who are supporting the care. This is really crucial for supporting engagement to care, linkage to care, and treatment adherence. There are 4 components of our linkage to care model that work together for each patient. The first is health promotion. That encourages risk reduction behaviors, and that happens through our community health workers' outreach, through education, and through one-on-one counseling that's developed within the community settings. The second is patient navigation, and that happens in the clinical setting, and that includes everything from accompanying clients to their appointments, helping them navigate the healthcare system, and ensuring that there's language support for clients when they see their primary care physician or specialist. Finally, there's benefits and, Next is there's follow-up teaching to clients on treatment adherence. So that is talking to clients about the importance of adherence to both medical appointments, follow-up tests, and other regimens. And then finally, there's benefits and service coordination. And that ensures that clients are provided with case management skills, that they have health insurance, that they can afford their medication, and that they're connected to all the services that they need. As you can see, there are 3 aspects of the linkage to care model that are shared across all 4 components. It's important that all parties in this system are engaged in assessment and planning to ensure that the client's needs are met. It's also critical that information is shared. This may mean the primary care physician requesting test results from the specialist that are then sent back to the medical home. It can also mean formal and informal case conferences that happen within the clinic setting. Outreach helps clients return to care when they've been lost, as well as actively re-engaging current clients when appointments are missed. Next slide, please. I'd also like to give you some background on our Hepatitis B Navigator Guide. As many of you know, patient navigation has been traditionally used in the cancer continuum of care and applied to diabetes, palliative care, and HIV/AIDS. The patient navigation model can also be adapted to serve the needs of individuals with chronic hepatitis B. So we created this training guide for organizations who are interested in training new lay individuals to serve as hepatitis patient navigators in both clinical and non-clinical settings. This is especially helpful within clinical settings. As you know, patient navigators are a type of community health worker. It's a critical type of community health worker who bridges the gap between the community and the clinic. While patient navigators reflect the communities that they serve, they are not necessarily people who are living with hepatitis B. Next slide, please. Through our CDC-funded cooperative grant, we began with identifying and screening individuals born in Asia and Africa in partnership with 12 ethnic-serving community-based organizations and 2 community health clinics, which see immigrant populations. This project is ongoing through September 2016, and our preliminary findings are showing very favorable results in the role of patient navigators to assure follow-up care for those positive affected individuals. Next slide. we really couldn't have achieved the success that was shown on that past slide without our community health workers who are doing education and outreach, and our hepatitis patient navigators that are working within the clinical setting. What we realized is that even though community health workers have a powerful impact within their communities, their community-based organizations, their faith communities, their neighborhoods, when they enter an FQHC or hospital, they become just another community member who is confused by this complex system, which has its own language, its own systems, its own structures, and its own barriers to navigate. So that experience led us to design this role of the hepatitis patient navigator to guide patients through and around barriers within the complex healthcare system. That ensures that timely diagnosis and also treatment, ongoing treatment for chronic hepatitis B. The barriers that each patient experiences could fall into a number of categories. I've listed them there. You know, they could run into financial barriers due to their health insurance or being able to afford medication, language or cultural barriers, communication barriers that are not about their language of origin, but just navigating the communication needs within the healthcare system. Transportation of getting to see their primary care physician or getting to see their specialist, bias around their culture, race, or age, or the stigma of being diagnosed with hepatitis B. So patient navigators are really key players in this continuum of care that bridges that gap between the clinic and community. Next slide, please. In a community-based organization, a program like care coordination can be really difficult without having all the right people around the table. Our model is a patient-centered program that's designed to meet our patients and clients within their community. The 3 Ps in care coordination consist of the patient navigators, and other program staff, and providers. Each member of this model is equally important to achieve coordination and a successful patient navigation program. Our objective is to support, equip, and empower patients so they become self-sufficient, that they're able to manage their own medical and social needs. By providing linkage to care in a timely manner and in a coordinated manner, patients are able to maintain medical stability and keep their viral load well controlled. We work together to support medication adherence, as well as assisting patients with gaining skills and knowledge needed to maintain a stable health status over time. Next slide, please. Just as our community health workers and our patient navigators empower patients and equip them, it's also important that you invest in your community health workers and your navigation team. Over the course of this project, the importance of training and technical assistance has been one of the enduring lessons that we've learned. We provide initial trainings for all of our team through a 2 full-day community health worker training workshop and also a 2 full-day patient navigator training workshop. But really one of the most exciting parts of this training is the half-day bi-directional joint training that brings together community health workers and patient navigators. As I mentioned earlier, CHWs and our navigators, along with the staff and providers, inhabit very different worlds. The community health workers are working in the neighborhoods at these small community-based organizations. The navigators are working in these health centers. By bringing them together and really understanding their different perspectives, getting a sense of what each group saw as the barriers to care for the patients, it was an incredibly helpful and powerful experience. Of course, that initial training isn't enough. You need to go back in and provide refresher trainings, have those 2-way conversations to understand what's happening in site, and also we recommend a minimum bi-monthly site visit. We often are on the phone or on email much more often than that. Next slide, please. It's also really important to understand the kind of micro environment of each clinic and to understand the barriers that exist within each clinic environment that the navigator will have to be helping the patient get around. We're working with 2 clinic systems within the same neighborhood, but even within these 2 clinics, there are very different issues when it comes to patient navigation. So this documentation of the current clinic screening, how referrals happen, how linkage to care happens, the protocols, the processes, will allow your entire team to identify those gaps and those opportunities for improvement so you can adequately support your navigators to overcome those. Next slide, please. Just as it's important to invest in your community health workers and your patient navigators, it's important to listen to the providers and to get their buy-in and their investment in the success of this program. As you know, silos can develop very easily within health systems. So you may have a situation where nurses are not talking to front desk staff, or physicians' assistants are, following their own kind of guidance and not really sharing that information with other medical assistants. So having those separate presentations to those groups is helpful. Also bringing them together and looking for those opportunities where there's a shared meeting and you can share that information across the system. As Dr. Kim mentioned earlier, we also have medical advisory board meetings, and those have been really helpful. That's another place where we have that kind of bi-directional sharing happen, where we'll have our patient navigators come in and present their experiences to the medical advisory board, and having those different perspectives shared around the table really helps us identify solutions to issues that we might not be able to see, our navigators might not be able to see, and the providers might not be able to see. When you bring all of those people to the same table, you can identify those solutions. Next slide. That's the end of our presentation. We would be happy to take your questions. I understand that you'll be submitting those through the question pane, and we're happy to answer them at the end of today's webinar.
Great, thanks so much, Dr. Kim and Angela. Yes, that's correct. Please continue to send your questions via the question box, and then we are reviewing them, and we'll get to them at the end of our presentations today. So now I'll turn it over to Nira Johnson, who's going to talk about patient navigation programs throughout New York City. Nira?
Okay, thank you so much. Again, my name is Nira Johnson. I work at the New York City Health Department in the Capacity Building and Program Implementation area. I've been here for about 8 years, and today I'm going to focus on the Hep B Patient Navigation Program. Next slide. Okay, so to give a little bit of context, there are about 100,000 people estimated to be living with chronic hepatitis B in New York City, and just as a comparison and to add to the illustration of the picture in New York City, there's about 146,500 people living with chronic hepatitis C in New York City. Like the rest of the nation, the majority of people with hepatitis B are foreign-born, and we have a pretty good picture of country of birth from our perinatal hepatitis B data, in which we see about 60% are born in China and 13.6 are born in Africa, and then the rest are from various countries of the world endemic with hepatitis B. Next. And generally speaking, in New York City, we estimate that approximately 50% of people are unaware of their viral hepatitis status, and many remain out of care. Next. So the New York City Health Department has worked on a variety of strategies over the years to increase linkage to care, including the development of patient education materials in language, which are mailed to every person reported with a positive hepatitis B or hepatitis C test result, and that includes information about where to find care. These are also, of course, distributed through our coalition meetings and outreach and training events. And we also have other exciting projects going on, like text and call-based linkage to care strategies. However, we have for quite a long time felt that the best way to really see change and movement along the care continuum is to administer direct service programs, which I'll discuss in a moment. Next slide. Okay, and additional examples of our patient education materials. Next slide. So we have managed the Hep-Free NYC network, which is comprised of the NYC Hepatitis C Task Force and NYC Hepatitis B Coalition for many years. And these coalitions bring together a wide variety of professionals working in the field. We have 4 quarterly NYC Hepatitis B Coalition meetings and additional Hep C Task Force meetings. And we have a robust online presence, including a website, social media, and e-newsletter. And through this process, we've formed a fairly cohesive group of community partners working on the advancement of hepatitis B and C in New York City. Other special initiatives we support are Team HBV, Coalition Against Hepatitis in People of African Origin, and then a patient navigator network of the Hep-Free NYC network that focuses on patient navigation, networking, sharing of best practices, and ideally utilizing, piloting some of the models that we've developed, and then sharing those models both in New York City and nationally. Next slide. So members of the NYC Hepatitis B Coalition and NYC Hepatitis C Task Force came together to advocate in 2014 for funding from New York City Council, which served to start the Check Hep B program, sustain an existing patient navigation program called Check Hep C, and start a hepatitis C peer navigation program, which was placed at all of the New York City syringe exchange programs. So the New York City Department of Health administers City Council funds, and our role was to develop the contracts, manage the contracts, and then develop the programs and monitor the programs. So we developed program protocols, program materials, including forms, guides, and patient education materials, database for both data documentation for the sites as well as reporting. We provided initial training to the sites funded and the navigators, and then provide monthly program management meetings at which we provide technical assistance and training. And then we conduct quality assurance and quality improvement activities, including close review of the data reported by the program and also site visits. And then we facilitate forums where the navigators and the sites can share best practices. The New York City Department of Health itself did not get any of the funding from City Council. All of the funding goes to the community programs. So because the funding amount was rather low and the New York City Department of Health wasn't provided with any funding to administer the programs, and also because of feedback we've gotten in some of our other programs in the past, such as Check Hep C, in which a streamlined program might be most beneficial, we attempted to kind of create the most streamlined, low threshold program possible that would require the least administrative support and while having the highest impact. So in our case, the Check Hep B patient navigation program, like I said, was modeled on the Check Hep C program, which began in 2012. It was funded by pharmaceutical companies originally, and that program provided funded patient navigation services as well as screening and some clinical mentoring for healthcare providers. We found that the greatest gaps in the care continuum in New York City were from positive test result and then through the medical evaluation and treatment initiation process, and we felt that that was the area in greatest need of support, and so devoted this program specifically to Linkage-to-Care for people who are already identified as chronic hepatitis B positive, and then once Linkage-to-Care care coordination services for to get through medical evaluation and treatment. The goal for each program, with one exception, with the enrollment goal was slightly different, was to enroll approximately 50 hepatitis B surface antigen positive patients at each site, and the primary goals were just to complete their medical evaluation, to be screened for cancer, and if they were deemed medically eligible for treatment, to assist with treatment initiation and adherence. So the funded programs were, I'll show you a map on the next page, but each site got about $63,000 for 1 year of service, and because it was City Council funding, the funding was actually available a few months after the beginning of the fiscal year. So really we had about 9 months to conduct the program and evaluate the program. Next slide. So here's a map of New York City, which shows where the Check Hep B program sites were in fiscal year 2015 and then 16. 2 new sites were added, which are designated with the label new. So as you see, they're in areas of the city with the greatest burden of hepatitis B, which also are areas of the city with greatest immigrant population. And the sites funded were African Services Committee, which is a community-based organization, and they focus primarily on outreach, Linkage-to-Care. Korean Community Services is also a community-based organization, also focused on outreach and Linkage-to-Care, and then retention and care. Charles V. Wang Community Health Center is a federally qualified health center, and they focused on clinical care coordination services, as did Bellevue Hospital Hepatitis Clinic. And then, as mentioned this year, fiscal year 2016, an additional FQHC Brooklyn Chinese Family Medical Center was added. They would also focus on care coordination services, and a new site for Charles V. Wang. So in our program, we had to develop a model that provided guidance for a patient navigator who was in what would be described as a community health worker role or a care coordinator type of role, so dual purpose. Next slide. So the patient navigator activities under this program were outreach and enrollment to the program. In some cases, that was outreach in the community. Some programs had supplemental funding for screening, for media. The funding for this program not specifically go towards, was not available for screening. They had to get additional grants for that. Assessment and development of a patient navigation care plan. So this was done just after enrollment, and depending on where the patient was receiving care, the patient navigator care plan encompassed tasks that were related to the Linkage-to-Care component, or in the case that they were within the clinical setting, the care coordination activities. The primary goal was linkage to hepatitis B medical care within a month, and once the patient was in clinical care, the Navigator conducted care coordination services, including accompaniment and reminders, referrals to supportive services, alcohol screening and counseling, health promotion, and in this second year of service, we have developed a health promotion guide with 4 standardized modules, which I'll describe in a moment. Contact notification, partner notification services as needed. We recommend that all of our patient navigators are certified as medical interpreters, because we found that this was a necessary task for their work. case conferences with the medical care team and the patient, treatment readiness and adherence counseling as needed, and then, of course, medication pharmacy coordination if necessary, and then discharge and transition planning. Next slide. So between the first and second year, we developed a variety of materials to support the patient navigator in conducting their activities. So we have a patient navigation form, which I'll be showing you on the next slide, which is both a documentation guide as well as a reporting form. So this includes demographic information, a brief patient navigation assessment to determine barriers to care, a care coordination log, a place to log the frequency of care coordination services, as well as some case notes, and then clinical care tracking through the care continuum and discharge information. We developed a patient navigation database, which is an exact reflection of the form that is submitted to us monthly. The database is in Microsoft Access currently. And then we developed health promotion guides that work to complement our patient education materials. And then based on the feedback from the patient navigators, we updated and improved these guides and materials from the inception of the program. This year, we've developed 2 new forms to support the navigators, a patient navigation care plan form where they document their care plan with the patient, and a treatment planning form. Next slide. Okay, so this is an image of the patient navigation form. So there's just one form, 2 sides that guides the entire process with the patient navigator undertakes with the patient. Next slide. And then this is a screenshot of the Access database. And in this Access database, the patient navigator documents the information collected in the patient navigator form. In some cases, some of the sites who have an electronic health record didn't use the paper form, but rather their own electronic health record as the primary data collection and tracking location, and then transcribed information to the database monthly for reporting purposes. So each of the tabs that you see there reflects a different section of the form from the previous slide. And it's very user-friendly, and the navigators have expressed that it was helpful to guide their work. Next slide. So as mentioned, we developed a health promotion guide this year. If you could click next slide, and we'll bring up another window. And the health promotion guide covers 4 major areas. Hep B basics, so basic information that everyone who is chronically infected should know. Getting ready for hepatitis B care, so this guides the navigator through the patient navigation assessment process that helps them to anticipate barriers the patient may possibly encounter in the linkage to care phase or in the engagement in care phase. If these are identified early, plans can be made to overcome any obstacle or put supports in place so that the patient will be able to get through the care continuum smoothly. If the patient is deemed medically eligible for treatment, the navigator would go through the Getting Ready for Treatment module, and then all patients are recommended to go through the Staying Healthy with Hepatitis B module anytime after the assessment. So if they're not going on treatment, they would still undergo the Staying Healthy with Hep B education component. And this relates to how do you protect others from hepatitis B and how do you maintain your own health. Next slide. We've developed a care plan for the patient navigator themselves. In many cases, there's a care plan that is prescribed by the provider. If you hit next slide, there will be some information that comes up. Sorry, animation. Okay, and then this is meant to be developed mutually by the navigator and the patient and agreed upon, almost like a contract. There's a place on the second side where the patient signs to acknowledge that they understand the plan ahead for them, they accept referrals, or they accept health goals such as alcohol reduction that have been mutually agreed upon and discussed. Next slide. We've developed a treatment planning form that is meant to be used and could be regardless of what medication the patient is prescribed, they could use one form which would document their regimen and then share with them side effects that they may experience, when they should call their doctor, suggest typical treatment adherence disruption that they should think about in advance as to whether they may come up, make a plan for overcoming them or avoiding any treatment disruptions, and then provides place to log key visits on the opposite side, which is not shown here. Next slide. So all of these tools and materials are meant to be used together. So the patient navigation care plan form, the patient navigation form and care plan is meant to conduct the assessment and then document referrals and mutually agree upon the plan ahead together. The health promotion guide helps the navigator, almost like a script or a training, in how to conduct the assessment and how to promote change if the patient does need to create some change to overcome particular barriers in care. So for example, if they do drink heavily, how can you reduce alcohol so that they can keep visits, for example. And then the supplemental materials are meant to complement the patient education components and are meant to be takeaways with the for the patient. Next slide. So in approximately 7 months of actual service, the program enrolled 185 patients. The majority or all were completed their patient navigation assessment. Within that time period only, 150 completed a Hep B medical evaluation, which we determined the complete Hep B medical evaluation was designated when the medical provider made a determination if the patient needed treatment or did not and just needed regular follow-up or monitoring. 53 patients were deemed treatment candidates, once again, just during that time period, and then 50 started treatment, which is pretty good. Next slide. In terms of patient characteristics, it was varied considerably by site. So at African Services Committee, obviously, the majority of patients, or all of the patients, were foreign-born and from 11 African countries. The Navigator spoke 7 languages himself and therefore was able to engage people from several countries. The majority were uninsured and the income was very low. At Charles Wang, they had an additional patient navigation program, and so this program was used specifically to enroll pregnant women, many of whom had temporary Medicaid, and the purpose of enrolling pregnant women was both to ensure that they had good care while pregnant, but also to facilitate engagement in care after the birth of the child, because we know that many women do fall out of hepatitis B care after the birth of their child. Next slide. Again, Korean Community Services was a community-based organization. The majority of patients were from Korea, great proportion uninsured, and At Bellevue Hospital Center, we have great diversity in terms of country of birth. Bellevue actually only delivered services for 2 months during this program period for a variety of reasons. They enrolled 39 patients just in 2 months and had over 100 within an additional few months. And then the majority, because it's a public hospital, are uninsured and again, very low income. Next slide. So what we found in this program, I think many other partners in the nation likely experience. So there's generally remains a lack of awareness about hepatitis B, even in high-risk population. We've done a variety of awareness and outreach campaigns, as have our community partners in New York City, and we just have seen that patient navigators who can do in-person outreach and or in a community health worker type of role and have access to populations at risk are critical for reaching people at risk in a more successful than awareness campaigns. So we'd like to continue supporting that approach. Hepatitis B stigma certainly still persists. In many cases, the Navigator reported that they were the only person the patient had disclosed their status to. So it's critical to continue this type of programming to ensure patients have the support. So as we know, when people are hiding their status, they often will delay care, or they have less success in remaining in care or following through with care recommendations. And many of the patients enrolled were either migrant workers or had very intensive work schedules in New York City, making high threshold programs challenging to participate in. So we just continue to believe that keeping the program as simple as possible, as low threshold as possible, is critical. Patient navigators from the target community seem to have the best results, so due to their linguistic and cultural competency. So in the case of African Services Committee, for instance, the patient navigator was from Senegal, and he had great success in engaging people from Senegal and other areas for which he spoke the language, but we feel that if we had had another patient navigator from another region of Africa, we likely could have engaged many, many more clients from those regions. And as mentioned, the medical interpretation is a critical skill. And of course, undocumented patients do face unique barriers, paying out of pocket even for very low cost care, and lack of awareness about the existence of low cost care despite outreach efforts. So we just need to continue to raise awareness and sustain these programs in the future. Next slide. So our next steps are to work at the health department to improve our direct-to-patient communication. So as mentioned in the beginning of the presentation, we send a letter to all newly reported cases, which we are hoping to enhance, and also do some more direct-to-patient text and call interventions that we're currently piloting in the Hep C field. And we also want to better use that direct-to-patient communication to promote our direct service patient navigation programs. We are developing tools such as an NYC Liver Health mobile app, and we're hoping to translate it into additional languages to provide some of these resources and guidance direct to patients and to patient navigators in the appropriate languages. We want to further develop programs like Check Hep B, expand them to additional sites, continue to improve our program design and tools, and then share models with other areas. And then one of the ways that we share our best practices and disseminate information, as well as learn what others are doing in the field, are working with our Hep-Free NYC Patient Navigator Network, through which we tour health facilities in New York City, as well as to support successful referral and knowledge of these types of programs, but then also share best practices. And that is it. Thank you so much.
Great. Thank you so much, Nara. Thank you to both of our presenters. That was really interesting to hear about the similar yet unique models that are being implemented in two pretty big cities. I wanted to go ahead and start our question and answer period. And we do have some questions that have come through the question box. The first question, a couple of questions, was to the Asian Health Coalition. And it is, was the CDC grant specifically for Asian Americans? Are the Asian Americans and African, I think they mean African immigrants, more prone to hepatitis B?
Hi, so this is Karen Kim. Thanks for the question. So this grant was targeting foreign-born Asian and African immigrants. I wouldn't necessarily say that any one population is more prone to hepatitis B, but there's a much higher prevalence because there is I guess the prevalence is so much higher within those populations. But if you were to put any other racial ethnic group in that same area, they would be at the same risk for chronic hepatitis B.
Great, thank you. The second question is also for the Asian Health Coalition. The question is, did you develop your own trainings for the patient navigators and community health workers? And would you be able to share your training materials with others?
Yes, thank you. That's a great question. We did develop our own trainings. We have a training both for community health workers and also for the hepatitis patient navigators. Because we're still kind of in process with all of our grant program, we're probably going to be making some changes to that, but we'd be happy to share the curriculum outline with you.
Great, thank you. And I can also, just to follow up on that, share that in the follow-up to all the attendees whenever you're ready. And this question, the next question is for Nara, New York City. What was the program protocol as regards to those who tested negative? Would they be vaccinated, or I think only high risk, those with high risk or negative would get vaccinated?
Okay, thanks. So in this particular program, because the funding was limited, we did try to focus enrollment on persons who were already known to be surface antigen positive. So if somebody was identified as negative, most of the programs funded actually have additional capacity to provide services such as vaccination for people who are susceptible. So most of them did provide that, but that was not reported to us as part of the program standard reporting data report. So in some cases, the patient navigator may have been involved in that, but we don't know the frequency of that occurred.
Mm-hmm. Okay, great, thank you. And there's a follow-up question, also to Nara. Are patient navigators provided with additional training on HIPAA and confidentiality?
So we provide basic training on HIPAA and confidentiality as part of our startup training, and this issue is sometimes addressed at meetings depending on the topic that we're covering, our monthly meetings. Most of the patient navigators, all of the patient navigators do work within a program that also provides confidentiality and HIPAA training. So the training that we are providing under this particular program reinforces that of their own organization's policies on training.
Right. Okay, great. And then folks are asking if the New York City Check Hep B Patient Navigator form, would it be possible to get a copy to use as a guide to create one for their clinic? This person is probably from an FQHC.
Yes. Absolutely. If they could reach out to me directly, it would be great.
Okay, great. And then this is a question, the next question is for Asian Health Coalition. How did you persuade the clinics to participate in the program, and how are you able to get nurses and physicians to attend the monthly meetings and presentations, knowing that I think they are busy, very busy seeing patients? Did you have any difficulty with this?
Yeah, so I think that's an outstanding question. So I think this is developing long-standing partnerships, kind of like a CBPR method almost, in engagement. And I also think thinking about what the win-win situation is. So when we did a baseline assessment, we realized that so many at-risk individuals were not being screened because of the lack of time and personnel. And so to be able to work both within their electronic medical records as well as to be able to actually place these patient navigators, so community-placed navigators into the healthcare system that were integrated into their system, was really key to being successful. In terms of the other thing, because as many of us know, the ability to understand the serological evaluation of people with hepatitis B is very challenging, so we did a lot of capacity building for physician and front-end staff to understand how they could better order things, and actually made that process a one-click process, so it was actually easier. So actually, I think the reason that there was such robust buy-in is not only did we include them sort of thinking about the process, but then develop policies and procedures that made the delivery of healthcare to this immigrant population actually easier for them.
Great. Great, thank you. And then our next question, and I'm not sure, and it might be for both programs, is how long is the patient navigation training?
This is Nira from New York. I'll just start. Ours was short, actually. Some of the navigators did have experience. We did a total of one-day training, and then we have the monthly program management meetings, which we really consider to be ongoing training. Again, these were fairly low amount of funding, so we tried to make the requirements of the programs as minimal as possible. So just about one day startup training.
This is Angela from Asian Health Coalition. We have a 2-day training, and again, we have the same experience where this capacity building within the clinic and these follow-up trainings and this follow-up communication is just as important as that initial investment.
Mm-hmm. Absolutely, thank you. And then I'm not sure if this was not covered during the presentation, but if you could, for Chicago, if you could talk a little bit about the recruitment of the navigators and the community health workers and that process and who you targeted.
So thanks for the question. So the recruitment of our community health workers really done in partnership with our community-based organizations that do provide a lot of direct services to the populations that we were targeting. And so most of the community-based organizations that we've been working with have community health workers that we were able to support for this process. In terms of the community health navigator, we really ideally wanted individuals that had some amount of health background, medical assistant level, and in one of our health systems that we worked with, they already had, I guess, sort of a navigator, a pseudo navigator program, caseworker type program that we were able to kind of retrofit our navigator program into. And so it really depended on which health system that you're talking about and what their needs were in terms of how we were able to select who the patient navigator was, because we really didn't want to disrupt the system. We really wanted to facilitate either existing resources or enhance existing resources that they had.
Right. Okay. Great. Thanks. And we have time for just one last question, and this is for Neera. How long did you receive the funding for, and once it runs out, how do you plan to sustain the program?
Great question and a great challenge. So this program was funded by New York City Council, and it's funded for 1 year at a time only. And unfortunately, because it was the first year, we weren't certain that they would refund the second year, and they did. So we are in our second year of service now, and we think that it will continue for at least several more years, but can't be sure of that until it's designated. So this instability is actually incredibly problematic. Some of the programs will continue services between funding cycles, and some can't sustain that. So in New York State, there are some efforts underway to work towards reimbursement of patient navigation or peer navigation. Specifically, there's a peer navigation certification that's now available through New York State, which likely will lead to Medicaid reimbursement. Unfortunately, there still isn't a hepatitis B or a hepatitis C patient navigation certification, which looks like it's going to lead towards reimbursement from health insurance. And I would just, to be honest, less so hepatitis B even than hepatitis C. So we currently do not have a sustainable source of funding for this resource available or dependent upon advocacy, and would love to work on identifying a sustainable source of funding if other partners in the nation are interested, working
Great.
towards sustained funding.
Absolutely. Thanks. And okay, I will squeeze one more question in. This is more of a medical question for Dr. Karen Kim. Are Africans, especially men, at a higher risk for liver cancer, if not more prone to Hep B?
So that's a great question. So African American men or African immigrant men are at extraordinarily high risk for liver cancer, and as a result, the screening guidelines for when we start looking for liver cancer for African American men only start at the age of 20. All other populations start between the ages of 40 and 50. So this is a very unique situation that we see only among African immigrant men. So yeah, this is a problem that we are trying to adjust our guidelines to accommodate the earlier age and onset of liver cancer for this group.
Okay, great, thank you. So I will now bring the webinar to a close. For those that asked about posting of this webinar, copies of the slides, yes, they will all be available within the next couple of weeks. We will send a follow-up message out to all the registrants and the attendees, so you'll have a direct link to those once they're finalized. And I wanted to thank everyone for joining today, especially thank our panelists for their time, Dr. Karen Kim, Angela Perfia, and Neera Johnson. Thank you so much for sharing the information with us. If you have any follow-up questions or you were unable to get to your question today, please feel free to send us your question via our email at connect@hepbunited.org, and please visit our website to check out the resources. And once you exit the webinar, please do take a moment to provide us with feedback via a short survey as you exit. Thank you all again. Have a great rest of the day.
Thank you. Bye.
Bye.